Okay.
You can start.
Okay, we can start now. Good morning, good afternoon, and good evening. I am Dr. Mohanad Insoor. I am the Executive Director of Eastern Mediterranean Public Health Network, Infinite. I am pleased to welcome all of you today in this Infinite webinar titled A New Lens for NCDs in the Context of COVID-19. I will facilitate this webinar together with Her Excellency Professor Raida Al-Qutb. Professor Raida is a member of the Jordan House of Senates and Professor of Public Health Sciences, School of Medicine at Jordan University. Professor Qutb is a medical doctor with doctorate in public health from Johns Hopkins University. She served as president and board member in several national, regional, and international bodies. Most welcome, Dr. Raida. It's our pleasure to have you with us today or this evening. As you know, non-communicable disease, NCDs, particularly cardiovascular disease, cancer, diabetes, and chronic respiratory diseases are the leading causes of death and disability globally, affecting more people than all other causes combined each year. The COVID-19 pandemic impacting the country's abilities to address and respond to COVID-19, on non-communicable diseases. This woke the global attention to the accountability of health system toward addressing the gaps in NCD's care while responding to COVID-19 crisis. This webinar aims mainly to bring experts together and exchange knowledge, best practices, and to provide answers to questions related to responding to NCDs during public health emergencies such as the COVID-19 pandemic. Gain in-depth knowledge about the essential preparedness steps to be taken by the health systems to reduce the impact of COVID-19 on non-communicable diseases. Explore applicable, sustainable solutions for integrating non-communicable disease services as a part of the COVID-19 response. And finally, provide lessons learned and their utilization for building resilient health system. It's my honor to introduce our first speaker for this webinar, Professor Alauddin Alwan. We are very lucky and we are honored to have Professor Alauddin Alwan with us this morning or this evening for our region. As you know Professor Alauddin Alwan, medical doctor and professor of global health at the University of Washington, USA, member of the Royal College of Physicians in UK. Dr. Alwan had several leading positions at the World Health Organization, including Assistant Director General for Non-Communicable Disease and Mental Health, and representative for the Director General for Emergencies and Health Action in Crisis. And Dr. Alauddin Alwan is the former regional director for WHO Eastern Mediterranean region. Before joining WHO and during WHO, Professor Alwan was the Minister of Health and Minister of Education in Iraq. It's our great honor and pleasure to have you today with us, Professor Alwan. Thank you very much. And the floor is yours, please, to start your presentation. Thank you very much.
So thank you very much, Dr. Mohanad. It's a great pleasure to be here with you today. And I really would like to thank you for inviting me to participate here. Thank you also for selecting this topic. I must really congratulate you on the excellent concept note and also the priorities of action that you highlighted in the note. I have a long-standing interest in non-communicable diseases, and I've also been involved in emergency preparedness and response, as you mentioned. Part of my WHO work focused also on emergencies, and I have been doing this as an ADG for Health Action Crisis in WHO in Geneva, but also when I was in EMRO. And in fact, the joint external evaluation, which is now a global tool, was actually finalized in EMRO in Cairo in 2016. We collaborated with WHO and with CDC when I was regional director. So this meeting actually takes me to two areas of great interest to me. And also a good part of my time since the end of my term in WHO in 2017 has been focusing on disease control priorities and universal health coverage, particularly focusing on the use of DCP3 evidence in constructing essential packages of health services. So let me go back to my presentation, and if I could share the presentation. I don't know whether you can see it now.
Yes, we can, Doctor.
You can see my presentation?
Yeah. Can you zoom it or project it? Just.
So I will, yes.
This is excellent. Thank you.
Yeah. So really, in responding to some of the questions you raise in your concept note, I will really focus on the links between the three areas that I mentioned, the NCD area, the emergency preparedness and response, and also the current pandemic, COVID pandemic. And the simple message I want to make in this presentation is that we have a crisis in three areas, not just the COVID crisis. And the underlying factors in the three areas are similar, and there is a common approach to address them. That's my key message today. This is a very challenging way forward if you really want to address the three crises that we currently have. But I think this is a challenge that has to be given a priority in global health if the failings in responding to COVID-19 are to be avoided. So let me start with where we are in non-communicable diseases. The leading causes of death globally, with around 17 million people dying every year prematurely before 70 and about 10 million before 1060. The world has the vision to tackle them, and there was a breakthrough made in 2011 at the United Nations General Assembly when a political declaration on NCDs that provides the vision, provides the roadmap to address the global challenge was actually endorsed by heads of states and government. This was followed in 2015 by another important development, which is the SDG target as part of which is 3.4 on reduction of 1/3 of premature mortality due to NCDs, mainly the four groups that you mentioned, Dr. Mohanad, through prevention and healthcare. But the progress that translates the vision and the roadmap into concrete action in countries, as we all know, has been very slow. And this is why I say it is a crisis. And this was the conclusion of the second UN meeting, because in 2014, after 3 years, the UN General Assembly had another meeting on NCDs, and they noted that the progress has been very slow. And then there was a call for countries to scale up, and in 2018, there was a third high-level meeting in New York, but again, there was no real response. And we know the reasons for the failure to take action. So the world is really off target in achieving the SDG target 3.4. And there is obviously, if I may say, a state of inertia, a state of frustration regarding NCDs at the level of the international community. So I keep on saying it is a crisis. So let's move to the second issue, which is the universal health coverage. And we know that we do have estimates that only between 1/3 to 1/2 of the world population have access to essential services, which include the NCD best buys. And before COVID-19, the world was already at risk of missing the SDG target on UHC, which is 3.8. And the data during the COVID crisis or the COVID pandemic indicate that there has been a considerable disruption of basic services in general. In fact, the World Bank estimates that COVID is likely to push more than 70 million or more 70 million people into extreme poverty. I say more because we already know that every year 100 million people are pushed below the poverty line because of health expenditures. But then with COVID, this has been exaggerated. And then we come to the third crisis, which is the pandemic preparedness. And the COVID-19 has demonstrated the lack of preparedness. The pandemic has actually exposed the major gaps in public health response. And although this was expected before COVID, we all were saying that low and middle income countries will do very badly if we have a pandemic, and this is what we have seen. But actually, the lesson that we are learning today during this pandemic is on the weak and fragmented response from high income countries. And so it's a basic problem. So now looking at the reasons behind the current crisis, there are a number of factors that are actually shared with what, if I can call it, the impasse or the deadlock that we see in NCDs and UHC areas. So weak public health leadership and strategic vision is unfortunately clearly seen in many high-income countries, let alone low and middle-income countries. The weak health systems, and particularly the primary care level, the low priority given to health, and the poor public financing within government budgets, the weak coordination and the weak engagement of non-health sectors, and also the political and commercial interest that we frequently see today in both low and middle income countries and also high income countries. So NCD control and the health system strengthening, as well as the pandemic preparedness, share actually all these factors. And on top of all this is the weakening of the multilateral system, if I can call it the multilateral system, and also the ineffective multi-sectoral mechanism. And here is an example of the gaps that we actually currently see in relation to non-communicable diseases. Major gaps in commitment, in health systems, in public health capacity, funding of the health sector, in multi-sectoral action, and in also the competing interest and obstructing forces. Here is another example on pandemic preparedness. This is just a map that shows the preparedness in 2019 before COVID. And you can see a number of countries that are green in this map. But actually, what is happening in COVID is that countries that are labeled green in this map have become red. So it just shows that the pandemic preparedness is an issue that has not been given a priority in all countries alike. So it's not just the low-income countries, but other countries have more or less the same problem. So what have we learned from the COVID-19 pandemic? So I think there is now conclusion that is accepted by all that we are not prepared, the world is not prepared for a pandemic or even a health emergency of the same dimension as COVID. We know that the current assessments that we are using to assess pandemic preparedness are not predictive. And the map I showed is a good example. We know that the national response in many countries has been very siloed. It has not given a priority to the serious gap that currently exists in the provision of essential care, particularly for non-communicable diseases. And we have seen that, because of what we actually see in terms of the state of preparedness, that this has not been on the national security agenda. And as a result of this, the public trust in governments and the public trust in the multilateral system has been eroded. Now, there are a number of vulnerabilities and challenges in the national public health systems. And I have just put three here: the challenges in strategic public health leadership and in essential public health functions. And I can repeat what I said before. This is not just an observation or a conclusion that relates to low and middle income countries. You know the kind of response in some of the high income countries, which clearly indicates that there is a problem in relation to public health leadership. There are major disruptions in access to essential healthcare, and there is a major impediment in the progress towards universal health coverage. And of course, we see substantial racial and ethnic disparities in healthcare, which has been exaggerated by COVID. Now, the Global Preparedness Monitoring Board has been focusing over the last 2 years on assessing preparedness and on identifying the key way forward. And these are some of the conclusions made for them on the multilateral system. This was the last point that I mentioned in the previous slide. And so there is consensus that the UN and other multilateral forums, the G7 met, more recently the G20 has met, and they have been struggling to fulfill the leadership and the coordination role in relation to COVID. And I think this is more or less the same situation in NCDs that we have been seeing since 2011. There is a weak role for the multilateral system in pushing the NCD agenda forward. And I think it's the same thing is happening in relation to universal health coverage. We've seen the limited international collaboration and the tendency for countries to retreat into nationalism. And there have been many examples over the last maybe 10 months. This is the COVID-A, or maybe even 11 months. And the COVID is a good example that reveals the cost of a weak multilateral system. The point I'm making here is that the same applies to NCDs and the same frustration in relation to universal health coverage. So let's come to the disruption on NCD services. And this is a WHO survey that has been conducted recently. I'm not going to talk a lot about the disruption of services because I know that other speakers in this webinar will be addressing this issue as well. But you can see that this is a major issue, and that at least 3/4 of the countries reporting or responding to this survey have reported considerable disruption of services, particularly focusing on the 3 groups of non-communicable diseases that Dr. Mohanad mentioned in his introductory remarks. And what are the causes for these disruption? Again, the same WHO survey provides a list of leading causes for this disruption: cancellation of elective care, the public transport issues that prevent people from reaching health facilities, the reassignment of staff because of COVID and the burden on healthcare, and the stockouts or the supply chain deficiencies and the gaps in certain essential diagnostics and medicines. So what are the strategic priorities? This is one of the major questions of this webinar that, again, Dr. Mohanad articulated at the beginning of this webinar. I have put 4 key strategic priorities that have to be addressed in any country that really needs to benefit from the lessons learned in COVID. One is strategic public health leadership. And I mentioned the essential public health functions. We had an exercise when I was in EMRO in developing some sort of an assessment tool for essential public health functions. And we piloted it in some countries. And one of the countries is a high income country in the region. And it demonstrated the kind of gaps that exist even in high income countries. And I think we all agree that in COVID, there are many examples of the gaps that exist. I think we need to take this opportunity to re-energize the international NCD agenda. It's 2011 and now almost 10 years, and the progress has been disappointing. Nothing wrong with the vision, nothing wrong with the roadmap, but there are factors that I mentioned in one of my slides that are impeding progress. And so there is a need to re-energize the international NCD agenda. I hope that in another opportunity, we can go a little bit more in depth into what can be done to do that. And the third strategic priority is the importance of integrating essential services and UHC into pandemic preparedness. This has to be included in the IHR and the pandemic preparedness monitoring framework that is adopted by all member states. And I can come back if I have time to this framework later on. And then finally, we really need, when we talk about essential services, we have to define what essential means. And so we're now talking about high impact and cost-effective interventions, a special focus on primary healthcare delivery platforms, which is the community, the health center level, and also the first level hospital. And here we're talking about the importance of every country developing a package of essential health interventions, which is the third key dimension of universal health coverage. So if we go a little bit deeper and look at the more specific and operational priorities, I have included here 5 of them. If you look at the kind of research that has been conducted over the last 10 or 11 months, it's a massive amount of research. But if you look at NCDs, you will see a very, very small proportion focusing on NCDs in this area. I think there has been some sort of an assessment by the Georgia Institute on this issue. And the conclusion is that NCD is not given any kind of priority in the research agenda on COVID-19 and in pandemic preparedness. So that is an extremely important issue. We need to review the NCD medicines and technologies in emergency health kits. We did this about maybe 5 or 6 years ago. I think it needs to be done now because these emergency health kits are often used in large-scale emergencies and in humanitarian work. And we need to ensure that NCD is adequately covered there. We need to establish and assess the innovative models for delivering healthcare. We have seen across the world that there have been some innovation in how essential health interventions are delivered using digital technology and other things. I think we see this in high-income countries, but also in low and middle-income countries. And this has to be strengthened. It needs to be assessed and expanded. And I think it would be very important that we start thinking seriously about the private sector. What is the role of the private sector in this? What is the experience in COVID so far? And how can we ensure that the role of the private sector in delivering these essential interventions, particularly NCD interventions, is strengthened? And finally, I think the same applies to civil society, both in NCDs, in UHC, and pandemic preparedness. What we have seen in NCDs over the last 10 years is that, you see NGOs and big NGOs at the global level. When you actually come at the national level, this has not really contributed in an adequate way to stimulating and promoting NCD or civil society or non-governmental organizations that defend NCDs. I don't think I have time, because I think I have taken all my time, but I wanted to just show one thing very quickly on the IHR monitoring and evaluation framework. These are the 4 areas where, pandemic preparedness is currently being assessed. One of them is the one I referred to at the beginning, the joint external evaluation. This is much more objective than the self-assessment. And that is the reason why it was invented in 2016. And the aim is to identify the gaps and to prioritize actions, and then to implement a plan which is financed. And these are the countries that have already conducted the JEE between 2016 and 2019. They're just over 100 countries. And what I am advocating, or maybe suggesting, these are the components of the areas that are assessed by the joint external evaluation. What is in red color here is what needs to be added. So in assessing pandemic preparedness, there is no emphasis and no priority on what actually happens to essential health services during emergencies or pandemics. And I think that component has to be added to the JEE. So thank you very much again. And I would be very interested in responding to any comments, suggestions, or questions.
Thank you. Thank you very much, Professor Alwan, for very informative talk and presentation. So this is very, very informative. Thank you very much. We will back to with more questions at the end of the session. If you allow me to move to the second speaker, I am pleased to present our second speaker today, Patricia Richard, the Chief of the Global Non-Communicable Disease Branch and Division of Global Health Protection, Centers of Global Health at the Centers for Disease Control and Prevention, USA, Atlanta. Patricia, before joining Global Health Protection, she has served as a senior scientific and leadership position in CDC and in US FDA. She also worked extensively with the World Health Organization on tobacco control efforts through the multi-country tobacco lab network. It's our pleasure to have you today with us as a speaker to Eastern Mediterranean region. So allow me in behalf of our region, Eastern Mediterranean region, to welcome you, and please with your presentation for 15 or 20 minutes, please. Thank you.
Thank you very much. And I have lost my computer connection, so I have dialed in by phone. So I apologize if I am my quality of my audio is suffering for that. But thank you very much. Good afternoon, good evening, good morning to everyone. And thank you to the organizers for the opportunity to present today. First slide. As you are aware, COVID-19 has had severe impacts on health services globally, including overwhelming demands being placed on the health system, resources and staff diverted to COVID-19 health services, disruption of supply chains, and misinformation and fear affecting non-COVID-19 healthcare access. As mentioned by Dr. Alwan, these disruptions are affecting care for non-communicable diseases, with 122 of 159 countries participating in the WHO rapid assessment, reporting a partial or complete disruption of NCD services, such as hypertension management, diabetes and diabetic complications management, cancer treatment. Can you please go back? I think you're getting a bit ahead of me. Thank you. Just stay there, please. Cancer treatment and cardiac emergency services. These trends are worrisome as there is concern that they may be followed by increases in patients presenting with progressed disease and urgent and preventable non-communicable disease events. Next slide, please. As we see here, 7 out of 10 deaths worldwide are due to non-communicable diseases. And you can see that cardiovascular disease is an especially large burden. 85% of premature deaths or deaths among those under the age of 70 occur in low and middle income countries. Next slide, please. Based on the current available evidence, patients with COVID-19 disease who have NCD comorbid, please go back. Please go back. Thank you. Based on the current available evidence, patients with COVID-19 disease who have NCD comorbidities are more likely to develop a more severe and course and progression of the disease. For example, obesity increases the risk for becoming severely ill from COVID-19. Please go back. In a meta-analysis, smokers were 1.5 times more likely to have severe complications from COVID-19 and had a higher mortality rate. Alcohol impairs the body's ability to fight infections from COVID-19. Physical activity is associated with prevention of heart disease, hypertension, and diabetes. Therefore, overweight and obesity are risk factors for severe COVID-19 disease. Air pollution compromises lung function, which increases the risk for vulnerability to respiratory infection, including COVID-19. Patients with diabetes are found to be up to 3 times more likely to have severe symptoms or die from COVID-19. Patients with chronic obstructive pulmonary disease are at increased risk of severe complications or death from COVID-19. Hypertension, cardiovascular disease, and cerebrovascular disease increase the odds for severe complications or death from COVID-19, and cancer patients are more likely to experience severe COVID-19 infections. Next slide, please. Here is a glimpse of the global data from a meta-analysis released this past June, showing comorbidities observed in COVID-19 patients. Patients with comorbidities should take all necessary precautions as they usually have a worse prognosis. Next slide, please. We see here a figure from a scientific statement put forth by the American Society for Preventive Cardiology. The figure illustrates the potential implications of COVID-19 on persons with or at high risk for cardiovascular disease. Data suggests that persons with underlying health conditions, such as cardiovascular disease, are at higher risk for severe illness from COVID-19 than those without these conditions. The increased morbidity and mortality from direct COVID-19 illness is represented by the first wave on the left. The second wave in the middle represents an increase in morbidity and mortality due to the delay or deferral of urgent cardiovascular disease interventions. This wave would include patients with cardiac symptoms who are unable or unwilling to obtain the necessary emergency care, perhaps due to overwhelmed health systems or fear of COVID exposure. The third wave represents the negative health effects resulting from disruptions to traditional outpatient and preventive care. For example, this wave would include patients for whom standard primary or secondary prevention services were interrupted. The chronology, magnitude, and duration of the second and third waves are for illustrative purposes, as current estimates are limited. Yet the figure clearly conveys the potential increases in preventable disease progression and death for those with or at high risk for cardiovascular disease whose care has been disrupted due to COVID-19. Next slide, please. Numerous professional and medical societies have launched a call for action to encourage patients with chronic illness to continue care. In the United States, the American Heart Association issued a press release with leadership from a number of other professional organizations, urging people to seek emergency care if they experience cardiac symptoms. The American College of Cardiology has stated that uninterrupted management of cardiac disease for older adults with cardiovascular disease is essential during the pandemic, potentially protecting against both CV events and increased vulnerability to COVID. And the American Society for Preventive Cardiology has underscored the importance of adaptation of continuity of CVD care strategies to local context to ensure ongoing care. Next slide, please. This statement made by the WHO Director General calls attention to the disruption in NCD services, stressing that countries must identify innovative ways to ensure that essential services for NCDs continue, even as countries fight COVID-19. On the next slide, we see the results of the WHO rapid assessment. Next slide, please. Positively, WHO has found in their recent rapid assessment that 2/3 of countries that responded to the survey have included NCD services in their national COVID-19 preparedness and response plans. Also encouraging are the survey's findings that alternative strategies have been established in most countries to support the people at highest risk to continue receiving treatment for NCDs. Notably, countries reported high rates of using telemedicine and triaging to address disruptions to care. Task shifting and novel supply chain or dispensing approaches were also frequently reported. These interventions fall solidly in the realm of organizational change. Next slide, please. In the healthcare setting, it's beneficial for high-risk patients with non-urgent care needs to reduce contact with health facilities when possible through alternative medication dispensing approaches, such as multi-month distribution of medicine and the collection of medicine in outside areas of health facility or community pickup points, as well as increasing use of telehealth. Next slide, please. Telehealth services are conducive to delivering acute, chronic, primary, and secondary and specialty care when in-person visits are not practical or feasible. Telehealth can be used to screen patients, maintain access to primary care providers and specialists, monitor clinical signs of certain chronic medical conditions, and provide coaching and support for patients managing chronic health conditions. Next slide, please. As healthcare workers are reallocated to support COVID-19 patients, other healthcare workers may need to provide critical services for people with NCDs. Task shifting and task sharing can assist in this situation. Reassigning tasks and shifting priorities can be leveraged to enhance continuity of care. Map tasks to identify gaps, distribute responsibilities, and improve workflow, and community health workers, counselors, and other lay workers may be able to assist with monitoring chronic patients in the community. Next slide, please. This difficult time has forced health systems to innovate and adapt quickly, yet it is promising that the benefits can be long-lasting. Health systems have identified new solutions showing that relatively minor changes to the physical or institutional environment can have a big cumulative impact. As we move forward, we can adopt best practices and continue to improve based on the lessons learned. For patients, these innovations may mean fewer in-person appointments, less transportation time and costs, shorter wait times in waiting areas and less congested waiting areas, reserving longer visits to address illness, multi-month dispensing of medications. For health facilities, the new practices may result in less congestion, less exposure for healthcare workers, more time for healthcare workers to focus on sick patients. Let us ensure that we take advantage of this surge in innovation to create positive, lasting benefits within health systems so that we are collectively better equipped to address non-communicable diseases going forward. Thank you.
Thank you very much, Dr. Patricia. This is very useful. We appreciate it. I think as we did with Professor Alwan, we will keep the question to the end of the session. I will now, Dr. Raida, if you can, just to hand over to Dr. Raida to continue facilitation the session. Please,
Okay.
Dr. Raida.
Thank you, Dr. Mohannad, and good evening and good morning and good afternoon, wherever you are. First, let me start by thanking Dr. Mohannad and his team for giving me this opportunity to be a facilitator in this very important webinar. I think this is not something new to Infinite. Infinite has been a leading organization in Jordan and in the region, and I very much value the time and the effort that it has taken to bring together this important webinar. And I would like also to thank Dr. Mohannad for giving us the opportunity to be a facilitator with the distinguished speakers, both I'm talking about Dr. Alwan, Dr. Ibtihal, and Dr. Patricia. All of them are very good people and old friends of mine. And also, I'd like to thank him for giving me the opportunity to also be among the lovely audience that we will be interacting with in a minute, in a few minutes, not in a minute. So let's now present our third speaker. Our third speaker is Dr. Ibtihal Fadil. She is the chairperson of the NCD Alliance for the Eastern Mediterranean region. She's a medical doctor with both a master's and a PhD in public health. And she has served as the WHO regional advisor for non-communicable diseases and has an in-depth knowledge and experience in this area. We would like to welcome Dr. Ibtihal in talking about, she will be given 15 minutes. She will be talking about bridging the gap, the accountability gap for MRO progress in combating NCDs at the COVID-19 era. So Dr. Ibtihal, please go ahead. You have 15 minutes and then we will see what will happen after that.
Thank you very much, Dr. Raida. Thank you, Dr. Mohannad and the Infinite colleagues for really selecting these topics, the non-communicable disease, and having this valuable conversation with esteemed speakers about non-communicable disease. And also, I would like to thank you for supporting the Regional Alliance and providing the platform for civil society to articulate the voices of the civil society. I would like also to start with few messages I need to articulate it throughout my presentation, as the previous speakers has very well mentioned regarding the COVID is a challenging time globally as well as in the Eastern Mediterranean region. So we have called it the double burden, and in some country of the region it is regarded as a treble burden with the area of crisis. The interface of COVID and NCD has been well reported with a high risk, and especially with country with a weak health system and a country with low resources in the region. While we are still not clear about the magnitude of the problem in our region, that clearly the impact of COVID is huge for most of the country in our region. I want to mention that to build back better, we need to engage the civil society and the people living with non-communicable disease to progress better for in terms of the NCD agenda. In the coming 15 minutes, I will be covering, I will be covering a little bit about NCD burden, the progress in the region, and also the context of COVID. And I was talking about the role of civil society in terms of accountability and engagement of people living with non-communicable disease. So when we describe the non-communicable disease in the region, we have a few points to mention. We need to remind ourselves that the region has seen a real surge of non-communicable disease, and all the estimated data show that non-communicable disease accounting for nearly 3/4 of all death in the region. There is a high prevalence of NCD risk factor. We have a country with the highest rate of diabetes globally. We have a high prevalence of hypertension, like I give you example from UAE, nearly 30, to Tunisia is over 40% of the population have hypertension. On individual level, we have nearly 150 million people living with non-communicable diseases. Of them, 100 million with diabetes, 100 million with hypertension, 50 million with diabetes, and 1.35 million with cancer. On top of that, we have a diverse health system. So we have the whole range from basically very weak health system to a moderate to somehow a strong health system. And this is based on the WHO categorization of a 3-level health system. 50% of the country in our region are facing acute and chronic emergency, political instability, very weak governance in some of the country. And this is definitely impacted heavily on the health services in the countries. So just to talk about the impact of COVID specifically in the Eastern Mediterranean region, I want to share with you some of the data I drew from the WHO website of the EMRO region, based on they have shown how I could say half of the scenario what happened in the region in terms of disruption of the services and related to COVID. So the survey, which has been carried out with all member states in May 2020, related to what services disruption in terms of COVID, what are the causes of disruption, and related to also the mitigated strategy and WHO guidance and tool required to overcome this gap. Here in this slide, we can see that there is a lot of disruption of the services. And I think this is no surprise for us, all of us. We are not surprised to have a disruption of services for hypertension, diabetes, and cancer, and so on. So in this slide, we can see clearly over half of the country surveyed, they have mentioned and reported there is a partial and complete stop of the services related to hypertension, 42 related to asthma, and 26 for cardiovascular emergency, as well as other services like cancer rehabilitation services, which is very important, as we know, in terms of the COVID recovery and so on. But I'm saying, like when they assess the causes for disruption, I see, like the main causes have to do with the situation. We had most of the Ministry of Health and the government in our region. They initiated a new protocol and guideline which prevent or close the clinics, close the health center, close all the other surgery and, like non-emergency surgery. There is a government guideline on lockdown and self-isolation. So people will definitely not appear for the health services. There is also an issue of worrying and concern. So most of the people who have been asked and interviewed on a different aspect, they have mentioning, like they were worried and concerned they get the viruses. So they are not appearing to the health services. The lockdown and the self-isolation which imposed during this year has also a much negative impact on other essential, we regarded essential NCD services like the screening, the awareness, and also some of the survey which is required. So we can see here, this is another a slide from WHO showing that, services such as screening, public screening, mass campaign, essential implementation of essential services is all impacted by the situation of COVID. To give one example, like I heard it from a colleague in Bahrain regarding breast cancer screening, they have mentioned, like, prior to the COVID, they have only 6% of the women appearing early in breast cancer, early stage in breast cancer. So imagine what would be the impact after COVID. That's unfortunately will definitely affect the progress. I mean, we are not in a good situation prior COVID, where the majority of the population in the region are not protected from the risk factor of non-communicable disease. So there is no good policy and legislation in place to protect people from unhealthy tobacco or unhealthy food or tobacco use. Most of the people in the region, we can see, like region like with the Yemen, Sudan, and so on, they are people suffer from undiagnosed and untreated. There is a weak health system, even with the country who used to be having a strong health system like Iraq, Libya, other countries in the picture. They have now with Syria, with the political conflicts, they have very weak health system, unable to respond to non-communicable disease needs. Majority of the people, they don't have health insurance to cover their needs, so they go out of pocket expenditure. There is a political inertia and commitment is with ineffective planning and no investment for non-communicable disease. There is also limited health literacy, and I will speak about health literacy when to the next slide. And also we are having a region with less civil society engagement and less people engaged in non-communicable disease agenda. So we are not in a good shape before the COVID, and the COVID came down. With the COVID, we have regressed very much back, and we still see, we don't know the estimate of that regression. So if we see that the NCD Countdown report published by the Lancet in September this year, 2020, indicate that most of the country of the region are tracking the progress on SDG target. What is the civil society role? I'm talking on behalf of the civil society in the region from the Eastern Mediterranean and NCD Alliance. We have 4 key areas we are working on, which is the awareness, advocacy, access to care, and accountability. And for the time limit today, I will be only focusing on 2 areas, which is the accountability angle and the engagement of the people with the NCD agenda. So, I want to share with you one of the things which we have done this year in relation to the civil society work in the region. To complement the WHO assessment on NCD services and performance, especially during COVID time, we need to understand the reality on the ground. We need to know the patient perspective, how the lived experience of people living with non-communicable disease, their challenges, priority, and what they are doing in terms of the coping mechanism. So our mission as a civil society is to advocate for the patient need and to advocate for patient rights. And we are also working on empowering the patient to be a change agent for the NCD agenda. I think we did a work, we did a series of physical consultation starting from December last year till August this year, 2020. And then we did an online consultation as well as, personal interview with the different people affected with non-communicable disease, including refugee and youth group, to assess their needs. And we came up with a report, this consultation report. We have shared it in many forums, along with a statement and policy brief describing the needs and priority, which is very unique priority for the people living in the region. I also want to, we have to emphasize this as a civil society. We have to empower these people to be able to voice their needs with the policymaker. I think we agree in our region. We have many organizations which has scaled up and enhanced the agenda of cancer, like example, using the voices of the people in the region, and they were very successful in that. This report, which produced by lately, will help to inform the agenda for non-communicable disease, as well as we use it as accountability tool to make all sectors accountable for the action for non-communicable disease. We quoted many people who have, expressed their challenge in achieving healthy lifestyle, which we are talking about, healthy food, exercise, and so on. They have many challenges in region to address that, to achieve that. And we should be realistic in what we are asking for. I mean, people who have a challenge in terms of financial maintenance of treatment, because the lockdown had created a financial difficulty and loss of income to many families. So we have things which is identified prior to to COVID, and we have things which identified after COVID and during COVID. And this, I think, it complements the work of WHO in terms of bringing the perspective of the patient into the story. Accountability, how much the civil society doing? Accountability is very things which we are promoting as a civil society. So building on the NCD Alliance survey 2019, they have identified a huge gap in the work of the civil society in accountability. And in this slide, you can see clearly that it's only few civil society have taken action in terms of accountability in the region. So there is a need to improve and enhance accountability in our region. And to this end, we are using the Toolkit, which is produced by the NCD Alliance, and you can, I'm happy to put the link to this toolkit. This toolkit will help the civil society to improve their practice and action in terms of accountability. So we need to have more shadow report. We need to have more report addressing, like case studies and practice related to the social determinant and healthy practice. This has to be very clearly addressed and very clearly articulated to the policymaker in the region. I think, I will not take more time. And my key message is to build back better. We have to know that NCD issue in the region, NCD is a leading cause for premature mortality and disability in the region. And investment in non-communicable disease prevention and treatment is crucial for health security and development in all countries of the region. The pandemic is a massive wake-up call for all leaders to build strong and resilient health system and to act on non-communicable disease. I strongly emphasize the need to engage the people living with non-communicable disease as we hear their story. Their voices is must in moving the agenda forward. Accountability is a key driver for non-communicable diseases. We need to strengthen the role of every sector, including the civil society, in tracking NCD programs by providing the reality on the ground. They providing what is going on and how we can cope with it and how we can mitigate the strategy forward. I need to also emphasize the critical role of the civil society in the region. Despite the weakness we have noted, there is a strong will and strong enthusiasm with the work with the civil society, and they are very important to build back better. We need more data on the impact of COVID on the people living with non-communicable disease, and that is one of the gaps we have identified. At the end, I would like to thank you very much, and I hope looking forward for your discussion and for more conversation during this session. Thank you very much. Back to you.
Okay, thank you very much, Dr. Ibtihal, for a very interesting presentation. And I think there's a lot to learn from this presentation. It was very evident in our countries how the civil society was not really involved in the wake of the COVID crisis. And I think this is something that one can not only observe, but can tap on, because had the governments associated or built on the existence of NGOs and civil society, it would have made its life much easier, because it could have reached people everywhere. It could have listened to the voices of people. But anyway, let's now be more optimistic and see maybe in the coming era, the voice of people and the voice of alliances such as the Alliance for NCD could be heard and could perhaps help governments in pursuing the NCD agenda in their own countries. Let me take a few questions before I pose a few questions to the participants. And I would like to address a question that has come from one of the audience, Dr. Ibrahim Khan. He's asking about the effects on mental health. How does COVID affect mental health, and how does this relate to NCD? And let me pose this question to Dr. Patricia, if possible, please.
Thank you. That is a very good question. And I think that mental health, as recognized, especially by WHO, is inextricably linked with non-communicable diseases. And I think that it provides an additional burden, not just for the patients that are living with chronic diseases, but this is an additional stress on healthcare workers that are in almost every scenario have been stretched to their limit in terms of providing round-the-clock care to patients. So we may indeed see that this arise, and we must be on guard for a rise in the effects of mental health, especially depression among the elderly, as they are impacted by social distancing and other mitigation measures.
Okay, thank you, Dr. Patricia. Let me take one more question. This is coming from Noor Abdelhadi. And the question is, how could, and I think this is addressed to Dr. Alwan, how could non-health private companies cooperate with health institutions regarding improving the healthcare situation amid this COVID-19 outbreak? And she also is asking about to what extent health institutions can help the private companies design the CSR programs that focus on this aspect. So to you, Dr. Ala.
So thank you, Dr.
Raida.
Can you repeat the second question, please?
The second question is to what extent health institutions can help private sector to apply their CSR, the social, the community social responsibility.
Yeah, that's a very, very good question. In my recommendations, I focused on the role of the private sector, because just an assessment of at least the countries I know, the role of the private sector has been missing in COVID. And if you look also at the assessments that are being carried out, including the JEE, to measure pandemic preparedness, you don't again see the private sector highlighted or given a priority. I think this is an area of work that has to be reconsidered. And it's very unfortunate that in the UHC area, in the universal health coverage area, the role of the private sector is also missed. So when we talk about, for example, health benefit packages designed for universal health coverage, and many countries are now moving in that direction, we agree that for the essential interventions for health, the public sector has to be responsible, and that most of these interventions have to be publicly financed. But at the same time, that does not mean that the private sector is not there. So I think there's a very important role for private sector in the delivery of health services, irrespective of who is actually financing these essential interventions. We have an experience, a recent experience in Pakistan, where a new essential package for health interventions has just been endorsed by the government and is currently being implemented. And this is one of the areas, exciting areas actually, where the private sector role will be seriously considered, particularly in terms of the delivery of the essential health interventions. So very important area, somewhat ignored in our public health initiatives. But I think if you really want to be realistic in how you can make significant progress in universal health coverage, this is an area of work where a lot of work is needed.
Yeah, thank you so much, Dr. Ala. There was a question that I found, I'm just trying to go back to that question. It is from Rawan, and I'm just trying to locate it again. Hold on, Rawan Saadi, and this question is also addressed to Dr. Patricia. And she's asking if you please could elaborate more on the novel health supply chain, as disruption of supply chain was encountered by most of the countries. And this has resulted in high demand on local market, which was already unprepared with scarce resources. So could you please discuss this, Dr. Patricia?
Thank you. I think most of attention has been paid to medicine distribution in terms of providing alternatives. For example, I know that in Sri Lanka, we helped with a survey of awareness regarding a government approach to distributing medication at pharmacies, so that there could be multiple points outside of healthcare facilities. There is also a sense that, and I know that this has been promoted by many organizations, that multi-month dispensed prescriptions is very helpful, so that you do not need to make as many trips to pick up medication. And that was the main point that I was making in that slide. And I don't know if Dr. Alwan has an additional point to make on that from the WHO recommendations.
Dr. Alwan, do you have anything to add?
That's fine. I think I support the response from Patricia.
Okay, I have one more question for Dr. Ibtihal. It comes from Salma Afifi, and she wants to ask you, Dr. Ibtihal, in your opinion, what is the important impact of 100 healthy people that was implemented in Egypt on NCDs? And do you recommend such approaches in reducing the impact of NCDs in other countries?
Sorry, Dr. Raida, you said 100?
Yes, it looks like there is
their national
yes.
Strategy, yes.
So it is 100 healthy people that was implemented in Egypt on NCD. And she's asking if you recommend such approaches in reducing the impact of NCDs in other countries. In case you are not aware of this, probably you can also comment, Dr. Ibtihal, about any of the success stories that you have encountered in the regions in which you have worked that has helped in achieving NCDs in the era of COVID.
Yeah, I think I know a little bit about the strategy in Egypt is very, many countries in our region have adopted in line with WHO recommendation their own, like national targets and strategy. Like I know one of them it's a very, you could say, optimistic, and people have to aspire for to have a target, which is a very good things we encourage. And I know from the civil society, because we have Egypt Ncd Alliance, and they are working along the government to address this issue of achieving that target. I think in our region we have many strong civil society for cancer, non-communicable disease. In general, they are very well positioned within the government, and they are engaged in the national planning, as well as currently with the COVID national emergency plan. They have involved them, and I can refer to like the one in Jordan, the King Hussein Cancer Center, working as along the government in area of cancer control, addressing all issue of cancer, and especially also cancer refugee. In terms of another example, like we see Pakistan, they are working with a global partner on area of trans fat. We have the Gulf Federation, they are working in area of volunteering for cancer treatment and cancer screening in low resources country. The advocacy work, which is done by organization like, give example, the Royal Health Awareness Society in Jordan, is tremendously good. They did with us a lot of training for people affected with non-communicable disease. So we have many good practice in the region, which has to be enhanced and scaled up. There is a lot of limitation for the work of the civil society, especially during COVID. As organization, as other, as the government organization, they have no capacity to do anything now, any event or campaign or anything outside. Even some of the organization, which I know, like in Saudi Arabia, they do delivery of medicine with the Ministry of Health. They are stopped from that and until, like 2-3 months. Similarly in Yemen, the cancer organization, they do delivery of medicine. They cannot do it because of the lockdown and isolation. So the civil society, as any other organization, they have to stick to the rules of the government. But beyond COVID, we are hoping that this will be, a new era for the civil society to work and will be acknowledged by the government to work with them. I'll stop here. Thank you. Over to you, Dr. Raida. You are muted.
Yes, thank you. Thank you for alarming me. There's one more question to you, Dr. Ibtihal. It comes from Marwis Amiri, and he's asking you if you can give examples of where the revised NCD Alliance Accountability Toolkit has been used in the context of COVID, and if there's any interesting results thereof.
Yeah, this one, the kits has been launched in February, early February this year, in the NCD Alliance Forum in Sharjah, what happened in Sharjah. As I said, it's supposed to be a sort of know-how to the civil society, how to approach the area of accountability. So the first one, which is using this, there is many examples, not from our region, outside the region, like in the Caribbean, they use the scorecard model to assess the contribution of the civil society. There is one example which all the country in the region have participated with, is the report on industry interference during COVID. So they have collected, the NCD Alliance have collected example of wrong interference of the industry during COVID. And we in our region, many of the organizations in our region have provided example like interference of Coca-Cola, interference of the private sector, and so on. So far, I think this is agenda for future training and future work, but we are already working along the global partner, the Global Alliance and other partner to provide, we are on a passive stage, we provide information, but we need to do more in the future.
Thank you, Dr. Abdihal. There's a very interesting question that comes from Dr. Iman Badran, and it is, I think I can address this to Dr. Patricia. She's asking about what are your suggestions to ensure the needs of children and adolescents with existing NCDs, such as asthma and type 1 diabetes?
I'm sorry, can you repeat the question? What is the recommendation?
So what are your suggestions to ensure that the needs of children and adolescents with NCDs, such as asthma and type 1 diabetes, are being assured in the COVID crisis? Interesting question.
It is an interesting question, and I think that it's a challenging question because chronic diseases are typically associated with adults, but that's a very valid point.
Yeah.
Asthma is a chronic condition and certainly puts an elevated risk. I think that the precautions and the mitigation strategies that we have are designed to protect all of society. Mask wearing, social distancing, perhaps working out arrangements with for remote monitoring with a child's physician so that you can communicate if there are any disease, any breathing difficulties via telehealth or telemedicine, if that is an option in the country. But of course, I would stress that this is not specific to children or adolescents, that it really would be an approach that would be an across society approach so that we could try to protect all vulnerable populations from complications and severe illness from COVID-19. But as a parent, I recognize it's challenging. It's challenging for with small children that they miss their playmates. So I think that maybe it just takes more creativity on the parts of the parents to make sure they're wearing the masks and to try to maintain the strategies that are needed.
Okay, thank you, Patricia. I think it is a really challenging question, and oftentimes we ignore these subgroups, these young people, although these are chronic diseases, so we have to be aware of that. I would like to address a question to Dr. Ala. Dr. Ala, what do you think is the intersection between universal health coverage, NCDs care, and COVID-19? Do we need to renew the commitment towards universal health coverage for the world to build back better Ncd services during and post-COVID-19? What do you think?
Yes, I think this is an excellent question. And I think this is a very strategic question too, because what we are seeing today is so many examples of failures to move forward in relation to NCDs and to universal health coverage. And a very good example is just looking at the targets set by the Sustainable Development Goals to see that we're really missing these two targets. And a very good example also is to look at how we have been managing to prepare for pandemics over the last so many years. And then, we have a situation where preparedness has been assessed to be very, very, very weak. And so, as I mentioned in my slides, I think the root causes for the failure to move forward, the root causes for that are impeding progress are more or less the same. I think public health capacity in countries is a big issue. I think there is some sort of a problem in, and when I talk about public health capacity, I'm not just talking about the number of healthcare professionals or the number of institutions, public health institutes or academic institutions working public health, because we know that there are some countries that have not been doing well in pandemic response, despite the fact that they are leading the world in these areas of work. So I think the public health capacity and public health leadership specifically is something that is needed to address the gaps in the three areas. I also think that the kind of health system weaknesses that currently exist in so many low and middle income countries, but also in some high income countries, and a very good example, of course, is the supply chain that we have seen in a number of examples in the industrialized world, that these weaknesses in health systems have impeded progress in the three areas. When we are unable to address the gaps in essential health services and in reaching the UHC target, we will definitely have major problems in addressing any pandemic. So it's a very close relationship. The root causes are there, the way forward is there, but then I think what we actually need is the solutions, and the solutions are known. But what you need is public health leadership and also political commitment and leadership. So in one of the questions, whether or not we have some approaches and some systems to mitigate the disruption of services that have been caused by COVID in relation to pediatric population. Are you hearing me? Sorry.
Yes. No, I'm sorry. So go ahead.
Yeah. So frankly speaking, and we have to be very, very open and say that these, the WHO survey and so many other data from a range of countries have shown that there is a major disruption in health services. And one of the reasons, and the key reason, is that we were not prepared. The world has not been prepared to protect the essential health services from the impact of pandemics or large-scale emergencies. And I think this is the issue. So how can we do that? And how can we ensure that when we prepare for the next pandemic, that this issue is not missed again? Because that is one of the most serious lessons learned that has led to loss of morbidity and loss of mortality, which could have been prevented by good preparedness. And I think this applies to countries. If you look at the mortality from COVID and the case fatality rates from COVID, it's very difficult to say that, well, in certain countries with resources, the mortality or the case fatality has been less now. And so why is this happening? And so I think this issue requires a great deal of thinking on how we redesign the way we are actually addressing these three key areas: the universal health coverage progress we're supposed to achieve in 2030, the NCD, despite the correct vision and correct and robust roadmap, and also in pandemic prevention. Are we going to have another pandemic in 2 years' time and have exactly the same kind of problems? I think these are the key issues that should receive a great deal of attention now by governments and also by the multilateral system or by the international community. So we see some good examples of achievements in NCDs in some countries, but these are fragmented. I mean, we we have a practical, feasible roadmap, and we have a comprehensive set of actions that can be implemented feasibly in all countries, irrespective of income. And we have a set of criteria or indicators to measure our progress. Let's look at this. Because if we continue to talk about small initiatives being successful in this country and in that country, these are marginal solutions. The solution has to be in addressing the major barriers and the root causes for the situation that we currently have in the three areas.
Okay, thank you, Dr. Ala. A very interesting discussion. And let me also add to what you've said, if the organizers allow me, that I have also a fear that with the response to COVID, most of the countries have spent a lot of money, probably inefficiently, because of the rush to do that, because they were not prepared, because of lack of emergency plans. And this would add to our existing low financing that goes for health and for the inefficiencies that we used to see in the health system. So, and now we are talking about vaccines, and vaccines need money, and the delivery of vaccines need a lot of resources. And this also will add to the issue. So probably we have to think very meticulously about the wave 2 and wave 3 that Patricia has mentioned, is that we don't want to increase and to increase the disruption and to the backlog of, let's say bad news that comes with the NCD negligence, as we have done probably a long time ago. So with these very interesting points and discussions, and there are a lot of questions that are there in the Q&A and also in the chat that I cannot take now, unfortunately, because of the lack of time, but definitely this would be taken further, and probably they could be posed to the speakers, and maybe answers could be sent to people. But anyway, let me say that it was really a great discussion that I had moderated, and I will now revert over to Dr. Mohannad to conclude this session.
Thank you very much, Dr. Raed. Actually, my mission to conclude the session is not easy after such a very rich discussion, but I will try. Allow me to start with quoting from Dr. Ibtihal. We were not in good shape before COVID-19. This is very important point. And quoting from Dr. Alwan, that we are not ready. We have evidences, scientific evidences from GEE, from IHR assessment that we were not ready. Now we are not ready. Before that, we are not ready. So we have a very strategic discussion we had this evening about triangle between universal health coverage, COVID-19 as emergency and preparedness example, and NCD, where we are, how we can move all these agendas and concepts together. The COVID-19 affected the NCD services globally, and estimated 3/4 of the countries reported a considerable degree in disruption of NCD service, a finding that has been consistent across all regions and income groups. COVID-19 pandemic is a massive wake-up call for building a strong, resilient health system to act on NCD. And I think I am here quoting from Dr. Ibtihal again. And we have also using COVID-19 pandemic to synergize NCD agenda. So as Dr. Alwan said, we have the agenda, it's very solid, we have very clear roadmap, but it's time to synergize NCD agenda. The importance of having essential health services package in joint evaluation external package addressing NCDs at the time of COVID-19 is fundamental for health security package. The importance of public health capacity and leadership are very important to fight against COVID-19. Disruption of NCDs care has damaging health and economic consequences, including severe disability, premature death, and billions of dollars in economic loss. Due to chronic and lifetime nature, NCDs often require repeating long-term interaction with the health system. Effective disease management and access to essential medicines or rehabilitation services. As Patricia mentioned, alternative strategies like triaging and telemedicine have been adopted by many countries over the world to address the disruption and the continuity of essential NCD health services. Pandemic preparedness today and in the future depends on universal health coverage, healthy population, and resilient, qualified, well-resourced health workforce. Accountability, in terms of accountability is a key driver for NCD action in Eastern Mediterranean region. This is essential for strengthening the role and involvement of region civil society organization and tracking the progress of preventing and controlling NCDs. And of course, we should not forget the countries. Countries must act urgently to mitigate the impact of NCDs while recognizing and compounding severity of other diseases like COVID. Countries need to tackle the impact of NCD in their national COVID-19 response and preparedness plans to develop a strong health system with integrated NCD care for the future health emergencies. And effective collaboration across sectors is needed to enhance the access to NCD affordable and quality treatment and prevention. And if you allow me just here, a global and regional and national team spirit and working together for combating NCDs and COVID-19 is a must, since all countries are only safe with a strong health system. This is in general, this is what I could capture. And I am sure that we have many things to add in our report. By the end of this webinar, on behalf of Infinite East Mediterranean Public Health Network, I would like to thank the respected speaker for their time and significant contribution. Of course, I would like to thank Dr. Raida for being with us this evening, and thank you all for attendance. Hopefully, they will bring their countries and organization to their take-home messages. Thank you all, and looking forward to seeing you in a new important forthcoming webinar. And here they're pushing me to say that there will be a poll at the end of the message, people to just, to address their comments and satisfaction. Thank you very much. It was our great honor to have you all. Thank you. Have a nice day.
Thank you. Thank you all. Thank you. Bye.
Thank you.
Bye.
Good night.
Good night.
Okay.